Diseases of ear, nose, and throat, and head and neck surgery by P.L. Dhingra. Chapter 5, Hearing Loss. Classification. Hearing loss can be divided into organic and non organic. Organic is further divided into conductive, sensorineural. Sensorineural is divided into sensory, which is cochlear, or neural. Neural is further divided into peripheral and central. Peripheral, where eighth nerve is involved, and central auditory pathways. Conductive hearing loss and its management. Any disease process which interferes with the conduction of sound to reach cochlea causes conductive hearing loss. The lesion may lie in the external ear and tympanic membrane, middle ear, or ossicles up to the stapediovestibular joint. The characteristics of conductive hearing loss: negative Rene test, that is, bone conduction more than air conduction. 2. Weber lateralized to poorer ear. 3. Normal airborne conduction, absolute bone conduction. And 4. Low frequencies affected more. 5. Audiometry shows bone conduction better than air conduction with airborne gap. Greater the airborne gap, more the conductive loss. 6. Loss is not more than 60 decibel. 7. Speech discrimination is good. Etiology: the cause may be congenital or acquired. Average hearing loss seen in different lesions of conductive apparatus. 1. Complete obstruction of ear canal, 30 decibel. 2. Perforation of tympanic membrane, 10 to 40 decibel. It varies and is directly proportional to the size of perforation. 3. Ossicular interruption with intact drum, 54 decibel. 4. Ossicular interruption with perforation, 38 decibel. 5. Malleus fixation, 10 to 25 decibel. 6. Closure of oval window, 60 decibel. Note here that ossicular interruption with intact drum causes more loss than ossicular interruption with perforated drum. Management. Most of the conductive hearing loss can be managed by medical or surgical means. Treatment of these conditions is discussed in respective sections. Briefly, it consists of: 1. Removal of canal obstructions, for example, impacted wax, foreign body, osteoma or exostosis, keratotic mass, benign or malignant tumors, or meatal atresia. 2. Removal of fluid, myringotomy with or without grommet insertion. 3. Removal of mass from middle ear, tympanotomy and removal of small middle ear tumors or cholesteatoma behind intact tympanic membrane. 4. Stapedectomy, as in autosclerotic fixation of stapes footplate. 5. Tympanoplasty, repair of perforation, ossicular chain, or both. 6. Hearing aid in cases where surgery is not possible, refused, or has failed. Tympanoplasty, it is an operation: 1. To eradicate disease in the middle ear, and 2. To reconstruct hearing mechanism. It may be combined with mastoidectomy if disease process so demands. The type of middle ear reconstruction depends on the damage present in the ear. The procedure may be limited to only the repair of tympanic membrane, myringoplasty, or to reconstruction of ossicular chain, ossiculoplasty, or both, tympanoplasty. Reconstructive surgery of the ear has been greatly facilitated by the development of operating microscope, microsurgical instruments, and biocompatible implant materials. From the physiology of hearing mechanism, the following principles can be deducted to restore hearing surgically. A. An intact tympanic membrane to provide large hyaluronic ratio between the tympanic membrane and stapes footplate. B. Ossicular chain to conduct sound from tympanic membrane to the oval window. C. Two functioning windows, one on the scala vestibuli to receive sound vibrations, and the other on the scala tympani to act as a relief window. If it is only one window, as in stapes fixation or closure of round window, there will be no movement of cochlear fluids, resulting in conductive hearing loss. D. Acoustic separation of two windows so that sound does not reach both windows simultaneously. It can be achieved by providing an intact tympanic membrane preferential pathway to one window, usually the oval window, by providing oscillator chain and by the presence of air in the middle ear. E. Functioning Eustachian tube to provide aeration to the middle ear. F. A functioning sensorineural apparatus, that is, the cochlea and the eighth nerve. Types of tympanoplasty. Wolstein classification of tympanoplasty into five types: type 1, type 2, type 3, type 4, and type 5. Type 1 defect is perforation of tympanic membrane, which is repaired with a graft. It is also called myringoplasty. Type 2 defect is perforation of tympanic membrane with erosion of malleus. Graft is placed on the incus or remnant of malleus. Type 3 malleus and incus are absent. Graft is placed directly on the stapes head. It is also called myringostapediopexy or columella tympanoplasty. Type 4 only the foot plate of stapes is present. It is exposed to the external ear and graft is placed between the oval and round windows. A narrow middle ear cavum minor is thus created to have an air pocket around the round window. A mucosa lined space extends from the Eustachian tube to the round window. Sound waves in this case act directly on the foot plate while round window has been shielded. Type 5 Stapes footplate is fixed, but round window is functioning. In such cases, another round window is created on the horizontal semicircular canal and covered with a graft, also called fenestration operation. Several modifications have appeared in the above classification and they mainly pertain to the types of ossicular reconstruction. Figure 5.1 Audiogram of right ear showing conductive hearing loss with airborne gap. Hearing loss in decibel, frequency in hertz, hearing loss in decibel from 0 to 110, and frequency in hertz from 0 to 125 to 8000. Here we have symbols used in audiogram chart. Modality ear, right and left. Air conduction unmasked, right, left. Air conduction masked, triangle, square. Bone conduction unmasked, right, left. Bone conduction masked, close bracket, open bracket, and close bracket. No response. Congenital causes of conductive hearing loss: meatal atresia, fixation of stapes foot plate, fixation of malleus head, ossicular discontinuity, congenital cholesteatoma. Acquired causes of conductive hearing loss: external ear, any obstruction in the ear canal, example wax, foreign body, furuncle, acute inflammatory swelling, benign or malignant tumor, or atresia of canal. Middle ear, A. Perforation of tympanic membrane, traumatic or infective. B. Fluid in the middle ear, that is, example, acute otitis media, serous otitis media, or hemotympanum. C. Mass in the middle ear, example, benign or malignant tumor. D. Disruption of ossicles, example, trauma to ossicular chain, chronic suppurative otitis media, and cholesteatoma. E. Fixation of ossicles, example, autosclerosis, tympanosclerosis, adhesive otitis media. F. Eustachian tube blockage, example, retracted tympanic membrane, serous otitis media. Figure 5.2 Types of tympanoplasty. The graft is progressively in contact with malleus type 1, incus type 2, stapes type 3, and stapes footplate type 4 or fenestra in horizontal semicircular canal type 5. In classical type 5, the graft was attached to promontory. This provides sound protection for round window while foot plate was directly exposed. Type 1 Meringoplasty, horizontal semicircular canal. Type 2, Type 3 Meringosepediopexy. Type 4, Type 5 Fenestration operation, horizontal semicircular canal. Meringoplasty, a underlay technique. Fascia graft is under the anterior annulus. It is supported by gel foam in the middle ear to prevent medial displacement. B. Overlay technique. Fascia graft lies lateral to the anterior annulus onto the anterior bony canal wall. It is placed medial to malleus handle to prevent lateralization. Meringoplasty. It is the repair of tympanic membrane. Graft materials of choice are temporalis fascia or perichondrium taken from the patient. Sometimes homografts such as dura, vein, fascia, or cadaver tympanic membrane are also used. Repair can be done by two techniques, the underlay or the overlay. In the underlay technique, margins of perforation are freshened and the graft is placed medial to perforation or tympanic annulus, if large and is supported by gel foam in the middle ear. In the overlay technique, the graft is placed lateral to fibrous layer of the tympanic membrane after carefully removing all squamous epithelium from the lateral surface of tympanic membrane remnant. Ossicular reconstruction. Ossicles are essential for transmission of sound from tympanic membrane to labyrinth. Several types of prostheses are available to replace ossicles depending on the ossicular defects. Autografts, ossicles, can be sculpted to bridge the gap. Homograft, preserved ossicles with or without tympanic membrane have been used but are difficult to procure and have danger of transmission of disease. At the time of ocular reconstruction in chronic otitis media, one should ensure that the middle ear is healthy and free of mucosal disease and cholesteatoma. The eustachian tube is function is good. The atelectatic middle ear shows poor eustachian tube function. In cases of canal wall up mastectomy done for cholesteatoma or active mucosal disease, the procedure is delayed for about 6 months to ensure that the ear is free of disease. Materials used for ocular reconstruction. Type of graft. Material remarks. Autograft materials incus head of malleus, cortical bone from mastoid. Remarks risk of harboring disease in bone graft, low cost, easily available. Allograft plastipore, that is polyethylene sponge, hydroxyapatite, HA implants, titanium implants, glass isomer, Teflon prosthesis, HA 50% plus titanium, HA plus silicon, HA flex HA, HA plus polyethylene, that is HAPEX. Ready made, easy to store and use, costly, likely to extrude. Homograft, preserved ossicles only, ossicles with tympanic membrane. Difficult to procure, risk of disease transmission. Figure 5.4, Ossicular reconstruction. Sculpted autografts or homograft ossicles have been used. A. Malleus stapes assembly. Modified incus graft connecting malleus handle with stapes head. B. Malleus footplate assembly. Modified malleus connecting malleus handle with stapes footplate. C. Modified incus connecting tympanic membrane to stapes head. malleus is missing. D. Modified incus connecting tympanic membrane to stapes head, stapes foot plate. Figure 5.5, hydroxyapatite processes, TORP, TORP, centered and offset types. B, this is top. B, PORP, PORP, centered and offset types, titanium processes. C, this is B. C is TORP for tympanic membrane and for the foot plate. D is PORP, stapes head and for tympanic membrane. Primary ossicular reconstruction can be performed in traumatic ossicular disruption, fixation of ossicles, canal wall down procedures where there is no mucosal disease or cholesteatoma. Types of processes. Incus processes used when incus is missing but the handle of malleus and stapes with superstructure is present and functional. Incus stapes processes used when incus and stapes superstructure are missing, malleus and stapes footplate are functional. 3. Partial ossicular replacement processes PORP used when malleus and incus are absent, stapes with superstructure is present and mobile. PORP is placed between tympanic membrane and stapes head. 4. Total ossicular replacement processes TORP used when malleus, incus, and stapes superstructure are absent. Only the stapes foot plate is present and is mobile. Sensory neural hearing loss and its management. Sensory neural hearing loss (SNHL) results from lesions of the cochlea, cranial nerve 8, or central auditory pathways. It may be present at birth, congenital, or may start later in life acquired. Characteristics of sensorineural hearing loss 1. A positive Rene's test, that is, air conduction more than bone conduction. 2. Weber lateralized to better ear. 3. Bone conduction reduced on Schwartz and absolute bone conduction tests. 4. More often involving higher frequencies. 5. No gap between air and bone conduction curve on audiometry. 6. Loss may exceed 60 decibel. 7. Speech discrimination is poor. 8. There is difficulty in hearing in the presence of noise. Audiogram of right ear showing sensorineural hearing loss with no airborne gap. So we can see the graph going down. Etiology. It is present at birth and is a result of anomalies of the inner ear or damage to the hearing apparatus by prenatal or perinatal factors. Acquired appears later in life. The cause may be genetic or non genetic. The genetic hearing loss may manifest late, delayed onset, and may affect only the hearing or be a part of the larger syndrome affecting other systems of the body as well. Syndromal. Common causes of acquired sensorineural hearing loss include infection of labyrinth, viral, bacterial, or spirococcal. 2. Trauma to labyrinth or cranial nerve 8, that is, fractures of temporal bone or concussion of the labyrinth or the ear surgery. 3. Noise induced hearing loss, NIHL. 4. Autotoxic drugs. 5. Presbycusis. 6. Meniere's disease. 7. Acoustic neuroma. 8. Sudden hearing loss. 9. Familial progressive sensorineural hearing loss. 10. Systemic disorders, that is, example, diabetes, hypothyroidism, kidney disease, autoimmune disorders, multiple sclerosis, blood dyscariasis. Diagnosis. History. It is important to know whether the disease is congenital or acquired, stationary or progressive, associated with other symptoms or not, involvement of other members of the family, and possible etiological factors. 2. Severity of deafness mild, moderate, moderately severe, severe, profound, or total. This can be found out on audiometry. 3. Type of audiogram whether loss is high frequency, low frequency, or mid frequency, or flat type. Site of lesion that is, cochlear, retrocochlear, or central. 5. Laboratory tests they depend on the etiology, suspected example, X rays or CT scans of temporal bone for evidence of bone destruction, congenital cholesteatoma, glomus tumor, middle ear malignancy, or acoustic neuroma, blood counts, leukemia, blood sugar, diabetes, serology for syphilis, thyroid functions, hypothyroidism, and kidney function tests, etc. Management. Early detection of sensorineural hearing loss is important as a measure as measures can be taken to stop its progress, reverse it, or to start an early rehabilitation program so essential for communication. Syphilis of the inner ear is treatable with high doses of penicillin and steroid with improvement in hearing. Hearing loss of hypothyroidism can be reversed with replacement therapy. Serous labyrinthitis can be reversed by attention to middle ear infection. Early management of the Meniere's disease can prevent further episodes of vertigo and hearing loss. Sensorineural hearing loss due to perilimb fistula can be corrected surgically by sealing the fistula in the oval or round window with fat. Ototoxic drugs should be used with care and discontinued if causing hearing loss. In many such cases, it may be possible to regain hearing, total or partial, if the drug is stopped. NIHL can be prevented from further deterioration if the person is removed from the noisy surrounding. Rehabilitation of hearing impairment with hearing aids and other devices is discussed in chapter 20, Rehabilitation of Hearing Impairment. Specific forms of hearing loss. Inflammations of labyrinth. It may be viral, bacterial, or syphilitic. 1. Viral labyrinthitis. Viruses usually reach the inner ear by bloodstream, affecting stria vascularis and then the endolymph and organ of Corti. Measles, mumps, and cytomegaloviruses are well documented to cause labyrinthitis. Several other viruses, example rubella, herpes zoster, herpes simplex, influenza, and Epstein-Barr, are clinically known to cause deafness, but direct proof of their invasion of labyrinth is lacking. Bacterial. Bacterial infections reach labyrinth through the middle ear, tympanogenic, or through CSF, meningogenic. Labyrinthitis as a complication of middle ear infection is discussed on page 49. Sensorineural hearing loss following meningitis is a well known clinical entity. Bacteria can invade the labyrinth along nerves, vessels, cochlear aqueduct, or endolymphatic sac. Membranous labyrinth is totally destroyed. Syphilitic. Sensorineural hearing loss is caused both by congenital and acquired syphilis. Congenital syphilis is of two types, the early form manifesting at the age of 2 or the late form manifesting at the age of 8 to 20. Syphilitic involvement of the inner ear can cause A. Sudden sensorineural hearing loss, which may be unilateral or bilateral. The latter is usually symmetrical in higher frequencies or it is flat type. B. Meniere syndrome with episodic vertigo, fluctuating hearing loss, tinnitus, and oral fullness, pictures simulating Meniere's disease. C. Henneberg sign. A positive fistula sign is in the absence of fistula. This is due to fibrous adhesions between the stapes foot plate and the membranous labyrinth. Tullio phenomenon in which loud sounds produce vertigo. Diagnosis of otosyphilis. can be made by other clinical evidence of late acquired or congenital syphilis, interstitial keratitis, Hutchinson teeth, saddle nose, nasal septal perforation, and frontal bossing, and the laboratory tests. Fluorescent treponema absorption test and venereal disease research laboratory VDRL or rapid plasma reagent that is RPR tests from CSF fluid are useful to establish the diagnosis. Treatment of autosyphilis includes IV penicillin and steroids. Familial progressive sensorineural hearing loss. It is a genetic disorder in which there is progressive degeneration of the cochlea starting in late childhood or early adult life. Hearing loss is bilateral with flat or basin shaped audiogram, but an excellent speech discrimination. Ototoxicity. Various drugs and chemicals can damage the inner ear and cause sensorineural hearing loss, tinnitus, and sometimes vertigo. 1. First, table 5.4 autotoxic drugs A. Aminoglycoside antibiotics, streptomycin, dihydrostreptomycin, gentamicin, tobramycin, neomycin, kanamycin, amikacin, netilmycin, sisomycin. B. Diuretics, furosemide, ethacyrenic acid, bumetanide. C. Antimalarials, quinine, chloroquine, hydroxychloroquine. D. Cytotoxic drugs, nitrogen mustard, mechlorethamine, cisplatin, carboplatin. E. Analgesics, salicylates, indomethacin, phenylbutazone, ibuprofen. Chemicals: alcohol, tobacco, marijuana, carbon monoxide poisoning. Miscellaneous: erythromycin, ampicillin, propranolol, propylthiouracil, deferoxamine. So, 1. Aminoglycoside antibiotics, streptomycin, gentamicin, and tobramycin are primarily vestibulotoxic. They selectively destroy type 1 hair cells of the crista ampullaris, but administered in large doses can also damage the cochlea. Neomycin, kanamycin, amikacin, sisomycin, and dihydrostreptomycin are cochlear toxic. They cause selective destruction of outer hair cells starting at the basal coil and progressing onto the apex of cochlea. Patients particularly are at risk are those A. having impaired renal function, B. elderly people older than the age of 65, C. concomitantly receiving other autotoxic drugs, D. those who have already received aminoglycoside antibiotics, E, who are receiving high doses of autotoxic drugs with high serum level of the drug, and F, who have genetic susceptibility to aminoglycosides. Here, the antibiotic binds to the ribosome and interferes with protein synthesis, thus causing death of the cochlear cells. Symptoms of ototoxicity, hearing loss, tinnitus, and or giddiness may manifest during treatment or after completion of the treatment. Delayed toxicity. Diuretics, furosemide, bumetanide, and ethoxynic acid are called loop diuretics as they block transport of sodium and chloride ions in the ascending loop of Henle. They are also known to cause edema and cystic changes in the stria vascularis of the cochlear duct. In most cases, the effect is reversible, but permanent damage may occur. Hearing loss may be bilateral and symmetrical or sometimes with sudden onset. Salicylate. Symptoms of salicylate toxicity are tinnitus and bilateral sensorineural hearing loss, particularly affecting higher frequencies. Site of lesion testing indicates cochlear involvement, but light and electron microscopy have failed to show any morphological changes in the hair cells. Possibly they interfere at enzymatic level. Hearing loss due to salicylates is reversible after the drug is discontinued. Sensorineural hearing loss has also been noted with other NSAIDs. Example: naproxen, piroxicam, and ketorolac, but is reversible. 4. Quinine. Autotoxic symptoms due to quinine are tinnitus and sensorineural hearing loss, both of which are reversible. Higher doses may cause permanent loss. The symptoms generally appear with prolonged medication but may occur with smaller doses in those who are susceptible. Congenital deafness and hypoplasia of cochlea have been reported in children whose mothers received this drug during the first trimester of pregnancy. Autotoxic effects of quinine are due to vasoconstriction in the small vessels of the cochlea and stria vascularis. 5. Chloroquine and hydroxychloroquine. Effect is similar to that of the quinine and cause reversible sensorineural hearing loss. Sometimes permanent deafness can result. 6. Cytotoxic drugs. Nitrogen mustard, cisplatin, and carboplatin can cause cochlear damage. They affect the outer hair cells of the cochlea. 7. Deferoxamine, desferrioxamine. It is a iron chelating substance used in the treatment of thalassaemic patients who receive repeated blood transfusions and in turn have high iron load. Like cisplatin and aminoglycosides, deferoxamine also cause high frequency sensorineural hearing loss. Onset of hearing loss is reversible when the drug is discontinued. It causes toxicity to nerves, children are more affected. 8. Miscellaneous. Isolated cases of deafness have been reported with erythromycin, ampicillin, and chloramphenicol, indomethacin, phenylbutazone, ibuprofen, tetanus antitoxin, propranolol, propylthiouracil. Alcohol, tobacco, and marijuana also cause damage to the inner ear. 9. Topical ear drops. Topical use of ear drops in the middle ear can also cause damage to the cochlea by absorption through oval and round windows. Deafness has occurred using chlorhexidine, which was used in the preparation of ear canal before surgery, or using ear drops containing aminoglycosides, example neomycin, framycetin, and gentamicin. Gentamicin is being used to destroy vestibular end organs by intratympanic injection in tympanitis disease. Autotoxic potential is also present in ear drops containing polymyxin B, propylene glycol, and antifungal agents. Use only approved autotopical drops for middle ear infection. D. Noise trauma. Hearing loss associated with exposure to noise has been well known in boiler makers, ironsmith and coppersmith, and artillerymen. artillerymen. Lately, noise trauma has assumed greater significance because of its being an occupational hazard. The compensations asked for and the responsibilities thrusted upon the employer and the employee to conserve hearing. Hearing loss caused by excessive noise can be divided into two groups. 1. Acoustic trauma. Permanent damage to hearing can be caused by a single brief exposure to very intense sound without being preceded by any temporary threshold shift, TTS, also called impulse noise. Such noise can arise from an explosion, gunfire, or powerful cracker and may reach or cross 140 decibel. Noise level of a gun or rifle may reach 140 to 170 decibel SPL. Sound pressure level. Such brief and loud noises mechanically damage organ of corti, tear Reisner's membrane, rupture hair cells, and by allowing mixing of perilymph and endolymph. A severe blast, in addition, may concomitantly damage the tympanic membrane and disrupt ossicles, further adding conductive hearing loss. Impulse noise may be as brief as zero point 0.2 millisecond. No impulse noise more than 140 decibel A is permitted. Noise induced hearing loss. Hearing loss in this case follows chronic exposure to intense sounds and seen in acoustic trauma and is mainly a hazard of noisy occupations. A. Temporary threshold shifts TTS. The hearing is impaired immediately after exposure to noise but recovers after an interval of few minutes or to few hours, even up to 2 weeks. Amount of TTS, temporary threshold shift, depends upon on the noise, its intensity, frequency, and duration. Permanent threshold shifts PTS. The hearing impairment is permanent and does not recover at all. The damage caused by noise trauma depends on several factors. One, frequency of noise. A frequency of 2000 to 3000 Hz causes more damage than lower or higher frequencies. 2. Intensity and duration of noise. As the intensity increases, permissible time for exposure is reduced. Table 5.5 gives the permissible limits of time for various intensity levels for the safety of ear. 3. Continuous versus interrupted noise. Continuous noise is more harmful. 4. Susceptibility of the individual. Degree of TTS and PTS varies in different individuals due to their susceptibility. 5. Pre existing ear disease. A noise of 90 decibel SPL 8 hour a day for 5 days per week is the maximum safe limit as recommended by Ministry of Labour, Government of India, model rules under permissible exposure in cases of continuous noise or a number of short term exposures. Noise level decibels 90, 92, 95, 97, 100, 102, 105, 110, and 115. Permitted daily exposure in hours. 5 decibel rule of time intensity states that any rise of 5 decibel noise level will reduce permitted noise exposure time to half. 90 decibel 8 hours, 92 decibel 6 hours, 95 decibel 4 hours, 97 decibel 3 hours, 100 decibels 2 hours, 102 decibels 11 by 2, 105 1, 110 half, 115 one fourth. A noise of 90 decibel SPL 8 hours per day for 5 days per week is the maximum safe limit as recommended by Ministry of Labour, Government of India, model rules under Factories Act. No exposure in excess of 115 decibel is to be permitted. No impulse noise of intensity greater than 140 decibel is permitted. The Noise Pollution Regulation and Control Rules 2000. Ministry of Environment and Forest, Government of India, has defined permissible limits of noise for various zones or areas. According to this, silent zones is 100 meters around premises of hospitals, nursing homes, educational institutions, and courts. Also, manufacture, sale, and the use of firecrackers generating sound above level of 125 decibel or 145 decibel pk from 4 meter distance from the point of bursting are not permitted. Environmental Protection Rules 2006. Decibel AI equal to A weighted impulse sound pressure level in decibels dB CPK equal to C weighted peak sound pressure in decibels. The audiogram in NIHL shows a typical notch at 4 kHz both for air and bone conduction. It is usually symmetrical on both sides. At this stage, the patient complains of high pitched tinnitus and difficulty in hearing in noisy surroundings but no difficulty in day to day hearing. As the duration of noise exposure increases, the notch deepens and also widens to involve lower and higher frequencies. Hearing impairment becomes clinically apparent to the patient when the frequencies of 500,000 and 2000 Hz, the speech frequencies, gets affected. The NIHL causes damage to hair cells starting in the basal turn of cochlea. Outer hair cells are affected before the inner hair cells. NIHL is preventable. Persons who have to work at places where noise is above 85 decibel should have pre-employment and then annual audiograms for early detection. Ear protectors, earplugs, or ear muffs should be used where noise levels exceed 85 decibel. They provide protection up to 35 decibel. If hearing impairment has already occurred, rehabilitation is similar to that of the employment for other SNHL. Non auditory effects of noise. Apart from hearing noise, noise can affect other systems of the body. It interferes with rest and sleep, causing chronic fatigue and stress. Through activation of the autonomic nervous system and pituitary adrenal axis, it causes annoyance and irritability. Hypertension and peptic ulcer have also been attributed to it. It also adversely affects task performance where communication through speech is required. Laryngeal problems have been noticed in workers who have to speak loudly in persistently noisy surroundings. Autoimmune immune mediated inner ear cell disease. Immune mediated inner ear disease, autoimmune sensorineural hearing loss cause progressive bilateral sensorineural hearing loss. It occurs between age of 40 to 50 years with equal incidence in both sexes. Nearly 50% of patients also experience vestibular symptoms such as disequilibrium, motion intolerance, positional or episodic vertigo. About 15% of patients have evidence of other autoimmune disorders such as ulcerative colitis, lupus, systemic lupus, rheumatoid arthritis, or multiple sclerosis. Moskiki et al. Defined the condition as bilateral sensorineural hearing loss more than or equal to 30 decibel at any frequency and evidence of progression in at least 1 year on two serial audiograms that are done at equal to or less than 3 months apart. Progression is defined as threshold shift of more than or equal to 15 decibel at one frequency or 10 decibel at two or more consecutive frequencies or significant change in speech discrimination. Permissible limits of noise as per the noise pollution zone or area. Day 6 a.m. 10 p.m. limits in decibel. Night 10 p.m. to 6 a.m. limits in decibel. Industrial zone 75 70, commercial zone 65 55, residential 55 45, silence 50 to 40. L equal means energy mean of noise level over a specific period. Early case of noise induced hearing loss. Note the dip at the 4000 Hz. Hearing attenuation provided by different devices. Cotton wool 5 decibel, earplug 15 to 30 decibel, mostly in range of 3 to 5 kilohertz, ear muffs 30 to 40 decibel, 500 hertz to 1000 hertz, earplugs plus muffs more than 40 decibel. Hearing protectors provide more attenuation in higher frequencies, 25 to 40 decibel for 1000 to 8000 Hz, while only 10 to 30 decibel attenuation for lower frequencies less than 500 Hz. Investigations 1. Audiogram. To establish above criteria, repeated audiograms can be taken at 1 month intervals. Audiogram may show loss at high and low frequencies. Speech audiograms. Speech discrimination is affected through though threshold of pure tones remain the same. Evoked response audiometry to exclude acoustic neuroma or multiple sclerosis. 4. Contrast enhanced MRI. 5. Blood test to exclude systemic autoimmune disorders. Total and differential counts ESR, rheumatoid factor, anti-nuclear antibodies, C3 and C4 complement levels, Raji cell assay for circulating immune complexes. 6. Western blot assay for anti HSP 70, anti heat shock protein 70 antibodies. Antigen used in this test is crude protein extract from bovine renal cells. It is not a specific test for diagnosis but correlates to both active disease and steroid responsiveness. Treatment: prednisolone 1 milligram per kg per day up to a total of 60 mg per day for adults for 4 weeks. Sometimes response is late. If no response is seen in 4 weeks, steroid is tapered off in 12 days. Responders continue till a plateau is reached and then continue on maintenance dose of 10 to 20 mg every other day for about 6 months. Side effects and risks of long term steroid therapy should be kept in mind. Those who cannot take steroids can be given methotrexate 15 mg per week for 6 to 8 weeks, and if the patient responds, continue it for 6 months. If no response is obtained, 6 to 8 weeks trials. Drug is discontinued. Alternative to methotrexate is cyclophosphamide, but it is more toxic. Other treatments include intratympanic steroid injection, systemic IgG injection, and plasmapheresis. Sudden hearing loss. Sudden sensorineural hearing loss is defined as 30 decibel or more of sensorineural hearing loss over at least three contiguous frequencies occurring within a period of 3 days or less. Mostly it is unilateral. It may be accompanied by tinnitus or temporary spell of vertigo. Etiology: most often the cause of sudden deafness remain obscure, in which case it is called idiopathic variety. In such cases, three etiological factors are considered: viral, vascular, and or the rupture of cochlear membranes. Spontaneous perilymph fistulae may form in the oval or round window. Other etiological factors which cause sudden deafness and must be excluded are listed below. Remember the mnemonic: in the very ear, 2. No major pathology. 1. Infections: mumps, herpes zoster, meningitis, encephalitis, syphilis, otitis media. 2. Trauma: head injury, ear operations, noise trauma, barotrauma, spontaneous rupture of cochlear membranes. 3. Vascular: hemorrhagic leukemia, embolism or thrombosis of labyrinth or cochlear artery or their vasospasm. They may be associated with diabetes, hypertension, polycythemia, macroglobulinemia, or sickle cell trait. 4. Ear otologic: Meniere's disease, Cogan syndrome, large vestibular aqueduct. 5. Toxic ototoxic drugs, insecticides. 6. Neoplastic: acoustic neuroma, metastasis in cerebellopontine angle, carcinomatous neuropathy. Miscellaneous: multiple sclerosis, hypothyroidism, sarcoidosis. 8. Psychogenic: Management. As far as possible, the etiology of sudden hearing loss should be discovered by detailed history, physical examination, and laboratory investigations. The investigations may be include audiometry, vestibular tests, imaging studies of temporal bones, sedimentation rate, tests for syphilis, diabetes, hypothyroidism, blood disorders, and lipid profiles. Some cases may require exploratory tympanotomy where perilymph fistula is strongly suspected. Where the cause still remains obscure, treatment is empirical and consists of 1. Bed rest, 2. Steroid therapy, prednisolone 40 to 60 mg in a single morning dose for 1 week and then tailored off in a period of 3 weeks. Steroids are anti inflammatory and relieve edema. They have been found useful in idiopathic sudden hearing loss of moderate degree. 3. Inhalation of carbogen. 5% carbon dioxide plus 95% oxygen. It increases cochlear blood flow and improves oxygenation. 4. Vasodilated drugs. 5. Low molecular weight dextrin. It decreases blood viscosity. It is contraindicated in cardiac failure and bleeding disorders. 6. Hyperbaric oxygen therapy, available only in selected centers. Hyperbaric oxygen raises concentration of oxygen in labyrinthine fluids and improve cochlear functions. 7. Low salt diet and a diuretic. It is empirical and has same benefit as in cases of Meniere's disease. 8. Intratympanic steroid therapy. It raises the local concentration of steroid in cochlear fluids, thus avoiding side effects of systemic therapy. Treatment. Many treatment protocols have been suggested for idiopathic sensorineural sudden hearing loss, but none of the none has shown significant benefit over the benefit of spontaneous recovery, with occurs in 50 to 60% of cases within first 2 weeks. None of the drugs, Dextrin 40, vasodilators, carbogen, inhalation, 5% carbon dioxide with 95% oxygen, diatriazoate, meglumine, have shown significant benefit. General prescribed medicines include steroids, inhalation of carbogen, low salt diet, and diuretic, hyperbaric oxygen. Prognosis. Fortunately, about half the patients of idiopathic sensorineural hearing loss recover spontaneously within 15 days. Chances of recovery are poor after 1 month. Severe hearing loss and that associated with vertigo have poor prognosis. Younger patients below 40 and those with moderate losses have better prognosis. Presbycusis. Sensory neural hearing loss associated with physiological aging process in the ear is called presbycusis. It usually manifests at the age of 65 but may do so early if there is an inheritary predisposition, chronic noise exposure, or generalized vascular disease. Four pathological types of presbycusis have been identified. 1. Sensory. This is characterized by degeneration of organ of corti, starting at the basal coil and progressing gradually to the apex. Higher frequencies are affected, but speech discrimination remains good. 2. Neural. This is characterized by degeneration of cells of spiral ganglia starting at the basal coil and progressing to the apex. Neurons of higher auditory pathways may also be affected. This manifests with high tone loss. But speech discrimination is poor and out of proportion to the pure tone loss. 3. Strial or metabolic. This is characterized by atrophy of stria vascularis in all turns of cochlea. In this, the physical and chemical processes of energy produced are affected. It runs in families. Audiogram is flat, but speech discrimination is good. 4. Cochlear conductive. This is due to stiffening of the basilar membrane, thus affecting its movement. Audiogram is sloping type. Patients of presbycusis have great difficulty in hearing the presence of background noise, though they may hear well in quiet surroundings. They may complain of speech being heard but not understood. Recruitment phenomenon is positive, and all sounds suddenly become intolerable when volume is raised. Tinnitus is another bothersome problem, and in some, it is the only complaint. Patients of presbycusis can be helped by a hearing aid. They should also have lessons in speech reading through visual cues. Curtailment of smoking and stimulants like tea and coffee may help to decrease tinnitus. Non organic hearing loss. In this type of hearing loss, there is no organic lesion. It is either due to malingering or is psychogenic. In the former, usually there is a motive to claim some compensation for being exposed to industrial noises, head injury, or ototoxic medication. Patient may present with any of the three clinical situations: 1. Total hearing loss in both ears; 2. Total hearing loss in one ear; and 3. Exaggerated loss in one ear or both ears. The responsibility of the physician is to find out if the patient is malingering. If so, what is the actual threshold of hearing? This is accomplished by high index of suspicion. Suspicion further rises when the patient makes exaggerated efforts to hear, frequently making requests to repeat the question or placing a cupped hand to the ear. 2. Inconsistent results on repeated pure tone and speech audiometry tests. Normally, the results of repeated tests are within plus 5 or minus 5 decibel. A variation greater than 15 decibel is diagnostic of non organic hearing loss, NOHL. 3. Absence of shadow curve. Normally, a shadow curve can be obtained while testing bone conduction of if the healthy ear is not masked. This is due to transcranial transmission of sound to healthy ear. Absence of this curve in a patient complaining of unilateral deafness is diagnostic of NOHL. Prognostic factor in sudden sensorineural hearing loss. Good prognosis and bad prognosis. Good prognosis, mild loss. Bad prognosis if it's severe loss. Good prognosis if it's low and medium frequency loss. Bad prognosis if high frequency loss is there. Recovering starting in 2 weeks is a good prognosis. Bad prognosis, recovery does not start in 2 weeks. Good prognosis if there is no history of vertigo. Bad prognosis if there is a history of vertigo. Good prognosis if it is in younger patients. Bad prognosis if it is in older patients. Early treatment, good prognosis. Late treatment, bad prognosis. Inconsistency in PTA and SRT. Normally, pure tone average PTA of three speech frequencies 500,000 and 2000 is within 10 decibel of speech reception threshold, SRT. And SRT is better than PTA by more than 10 decibel points to NOHL. Stenger test. It can be done with a pair of identical tuning forks or double channel audiometry meter. Principle involved is that of if a tone of two intensities, one greater than the other, is delivered to two ears simultaneously, only the ear which receives the tone of greater intensity will hear it. To do this, take two tuning forks of equal frequencies, strike and keep them approximately 25 centimeters from each patient. Patient will claim to hear it on in the normal ear. Now bring the tuning fork on the side of feigns the deafness to within 8 centimeter, keeping the tuning fork on normal side at the same distance. The patient will deny hearing anything even though tuning fork is on normal side is where it could be heard earlier. A person with true deafness should continue to hear on the normal side. Patient should be blindfolded during this test. This same test can be performed with a two channel audiometer using pure tone or speech signals. 6. Acoustic reflex threshold. Normally, stapedial reflex is elicited at 70 to 100 decibel sensation level if patient claims total deafness, but the reflex can be elicited, indicates NOHL. 7. Electric response audiometry. It is very useful in NOHL and can establish hearing or acuity of the person to within 5 to 10 decibel of actual threshold. Social and legal aspects of hearing loss. Hearing loss and deafness. Hearing loss is impairment of hearing and its severity may vary from mild to severe or profound, while the term deafness is used when there is little or no hearing at all. In some countries, this rigid differentiation is not made. They use the term deafness to denote any degree of hearing loss, irrespective of its severity. In 1980, WHO recommended that the term deaf should be applied only to those individuals who are hearing impairment is so severe that they are unable to benefit from any type of amplification. A similar definition is used in India while extending benefits to the hearing handicap. Degree of hearing loss, WHO classification. WHO 1980 recommended the following classification on the basis of pure tone audiogram, taking the average of the thresholds of hearing for frequencies of 500,000 and 2000 Hz with reference to ISO R 389 to 1970. International calibration of audiometers. Degree of hearing loss mild 26 to 40, moderate 41 to 55, moderately severe 56 to 70 decibel, severe 71 to 91 decibel, profound more than 91 decibel, and total. From this, it is implied that there is no apparent impairment of hearing from 0 to 25 decibel. The disability to understand speech with different degrees of hearing loss is given in table 15 5.9. Impairment, disability, and handicap. When a disease process strikes an organ or a system, it causes an impairment either in structure or function. But this impairment may or may not become clinically manifested. When impairment affects the ability to perform certain functions in the range considered normal for those individuals is called disability. The disability further restricts the duties and roles expected from an individual by the society and is called handicapped. Classification of hearing loss. 95% of population has thresholds between minus 10 to plus 10 decibel hearing loss. So this is a minimal hearing loss is 15 to 25 decibel. 15 to 25 decibel. Moderate hearing loss, mild hearing loss is from 26 to 40 decibel. Moderate hearing loss 41 to 55 decibel. Moderately severe hearing loss 56 to 70. Severe hearing loss 71 to 91. And profound hearing loss more than 91 decibel. Hearing loss and difficulty in hearing speech. Hearing threshold is better in better year. Average of 500,000 2000 Hz. Degree of impairment, WHO classification, and ability to understand speech. 0 to 25 not significant, no significant difficulty with faint speech. 26 to 40 mild, difficulty with faint speech. 41 to 55 moderate, frequent difficulty with normal speech. 56 to 70 decibel moderately severe, frequently difficult even with loud speech. 71 to 90 severe, can understand only shouted or amplified speech. 91 above profound, usually cannot understand even amplified speech. To exemplify injury, disease to the ear may result in hearing impairment, which, depending on its severity, will affect the individual's ability to hear and perform certain activities, disability, and will be termed handicapped by the society. Disease, impairment, disability, and handicap. Degree of handicap. Sometimes it is desired to express the degree desired to degree of handicap. Sometimes it is desired to express the impairment and handicap in terms of percentage for the purpose of compensation. Different countries and professional bodies have adopted their own system to calculate this percentage. One of the methods to find hearing handicapped is given below. 1. Take an audiogram and calculate the average of thresholds of hearing for frequencies of 500,000 and 2,000, say A. Detect from it 25 decibel, that is, there's no impairment up to 25 decibel, that is A minus 25. Multiply it by 1.5, that is A minus 25, in close the bracket, into 1.5. This is the percentage of hearing impairment for the ear. Similarly, calculate the percentage of hearing impairment for the other ear. Total percentage handicap of that individual. Better ear percentage into 5 plus worse ear percentage divided by 6. Example, hertz 1000, 500,000, 2000 hertz and average. Right ear 60, 75, 90. Left ear 30, 45, 60. Impairment, the right 75 minus 25, 50, 50 into 1.5, 75 percentage. Impairment in the left, 20, 45 minus 25 equal to 20, 20 into 1.5 equal to 30 percentage. Total handicap, 35 into 5, close the bracket, plus 75 divided by 6, 225 divided by 6 equal to 37.5 percentage, that is round off 38 percentage. In the above calculation, only three speech frequencies, 500,000 and 2,000, are taken into account, but it is felt that frequencies of 3,000 is important for hearing in the presence of noise and should be taken into consideration account. American Academy of Ophthalmology and Otorhinolaryngology recommends that takes into account the average of four frequencies, 500,000, 2,000, and 3,000 hertz when calculating the handicap. Government of India reserved certain percentage of vacancies in group C and D in favor of being physically handicapped and the extent certain other benefits. It also has recommended the classification based on permanent permanent of percentage of impairment and the tests required to be performed. Brochure on reservation and concessions for physically handicapped in central government services published by Ministry of Personnel, Public Grievances and Pensions, Department of Personnel and Training. Unilateral hearing loss. Unilateral hearing loss, even though total, does not produce a serious handicap or affect the speech, but it impairs localization of sound source, difficulty in discrimination of speech in the presence of background noise, and in some difficulty at meeting or in classroom when the speaker is in the side of the affected ear. It should also alert the individual that he or she does not have a spare or reserve ear and has to take all precautions for the safety of the only hearing ear. Also, the surgeon should be careful when he is or she is called upon to operate on this only hearing aid. Yeah. Bone anchored hearing aids are the treatment of choice for management of single sided deafness. This is the recommendation.